All right, let's dive right into this. Welcome to today's explainer. We're throwing on our detective hats because we've got some of the most elusive and frankly deadly culprits in clinical microbiology to track down: rare fungal pathogens. Whether you're staring down a high-stakes exam or working real-world diagnostics, missing these microscopic mimics isn't just dropping a point, it's a critical error. So we're going to do a rapid-fire run through the absolute highest yield diagnostic clues, traps, and lab findings that you literally have to know.
Just think about this extreme number for a second. 70 to 1. That is the staggering male-to-female ratio for the chronic form of paracoccidioidomycosis. I mean, it's the highest male predominance of any infection we currently know of. Unforgettable medical facts like this, they're our first vital clues, totally setting the stage for how we investigate these incredibly specific fungal signatures.
Let's move to the roadmap and see how this all builds. We've got 4 steps today. First, morphological clues. Second, culture colors and stains. Third, diagnostic traps and mimics. And finally, an essential exam traps review.
Okay, part 1, morphological clues, identifying the unforgettable shapes. You've gotta love the classic mariner's wheel. If you have a sample showing a central yeast with multiple daughter cells attached by narrow neck buds, literally looking just like a ship's steering wheel, you have unequivocally nailed down Paracoccidioides brasiliensis. Definitely keep this specific shape in the back of your mind, especially if you're presented with a middle-aged male patient from Brazil or Colombia who has severe mucocutaneous ulcers in the upper respiratory tract.
Now, what's really interesting is the fruit-like morphology you can find. Septate, curved, sickle shapes. Those are the famous banana-shaped macrocornidia. The second you isolate these on a culture, boom, you are dealing with Fusarium species. This shape is an absolute giveaway. It's totally crucial for diagnosing severe fusariosis, particularly if you have a profoundly neutropenic patient coming in with a fever and really painful nodular skin lesions.
Next up is a super critical comparison. So both Toleromyces marnifae and histoplasma can cause some really severe disseminated disease, right? But pay close attention to how they replicate. Toleromyces divides by a central septum, a process known as bipolar fission. Histoplasma, on the other hand, replicates by narrow-based budding. Recognizing that central septum in Toleromyces is a major morphological differentiator when you're analyzing a slide.
Then we've got arthroconidia. These are those distinct barrel-shaped cells found in tissue right alongside yeast and hyphae. Honestly, identifying arthroconidia is the absolute key to telling Trichosporon asahi apart from its invasive candidiasis mimic. Candida just doesn't have arthroconidia. So if you spot the barrel shapes, you know for sure it's Trichosporon.
Moving right along to part 2, culture, colors, and special stains, exploring the lab visually. Imagine your lab reports a red diffusible pigment growing in a mold culture at room temperature. Stop right there. That red pigment is a dead giveaway. It's totally pathognomonic for Toleromyces marnifae. You're going to see this pretty often in advanced AIDS cases with molluscum contagiosum-like skin lesions, especially if the patient has a history of travel to Southeast Asia or, specifically, exposure to bamboo rats.
So the crucial point for our pigmented molds, the phaeohyphomycosis, is that staining is literally everything. On a standard H&E stain, sure, you'll see golden brown pigmented hyphae, but to be absolutely certain, you have to use a Fontana Masson stain. This special stain specifically highlights the melanin in the fungal cell wall. It acts as the ultimate confirmatory test for these really tricky demataceous molds.
Time for part 3, diagnostic traps and mimics, how not to be fooled.
All right, here's a direct, high-yield question for you. Which pathogen causes a false positive cryptococcal antigen, or CRAG test? Think about it for a second. If you get a positive CRAG, but the clinical picture just doesn't quite match Cryptococcus, what else could it be?
The answer is trichosporinosis. Trichosporin actually shares polysaccharide antigens with Cryptococcus, which is exactly what triggers that false positive on the test. This is a classic, top-tier exam trap and a genuinely dangerous clinical pitfall. You definitely don't want shared antigens leading you down the wrong treatment path.
And the antigen traps do not stop there. Emergeromyces is a really double mimic. Not only does it morphologically resemble histoplasma as a narrow-based budding yeast, but it also cross-reacts with a histoplasma antigen test. You've got to be incredibly careful with identification here, especially when dealing with immunocompromised patients from regions where this is endemic.
And think about this key divergence. There's actually a 50-50 split in blood culture positivity for Fusarium dissemination. That might not sound super amazing on its own,
But contrast it with Aspergillus, which Fusarium heavily mimics under the microscope with its septate hyphae. Aspergillus blood cultures are almost always negative. So a positive blood culture with a mold should immediately make you think Fusarium.
Let's rapidly fire off some contextual clues for phaeohyphomycoses. Remember, these are melanin-producing molds. They actually made massive headlines back in 2012 during the extraohilum outbreak, which was linked to contaminated steroid injections that caused just terrible CNS infections. Genetically, patients with CARD9 and DECTIN1 mutations are at a much higher risk. And never, ever forget that species like C. bantiana are fiercely neurotropic, often causing indolent brain abscesses.
Wrapping up with Part 4, Essential Exam Traps Review, Rapid Fire Consolidation. Let's sprint through this. First up in our rapid fire review, Scatosporium opiospermum complex. The classic keyword association you've just got to burn into your brain here is near drowning. It is highly associated with near drowning events, causing severe lung and CNS infections, even in completely immunocompetent patients who happen to aspirate contaminated water. Let's review some crucial treatments. For paracoccidioidomycosis and toleromyces, the drug of choice is itraconazole. But for Scedosporium and trichosporinosis, their drug of choice is voriconazole. This distinction is vital because both Scedosporium and trichosporon are notably resistant to amphotericin B. Giving amphotericin to these patients could honestly be a fatal mistake.
Speaking of fatal mistakes, here is a truly terrifying clinical question for you. Which fungus is resistant to virtually all commercially available antifungals?
The grim answer is Lamintospora prolificans. It carries a horrifying 85 to 100% mortality rate purely due to extreme pan resistance. It's an absolute clinical nightmare because it mimics Aspergillus on histology, but standard treatments will completely fail. Exact, rapid lab identification is literally the only way you even have a fighting chance here.
All right, here we go. This is the ultimate summary of our diagnostic detective guide. 70-to-1 male ratio, that means paracoccidiodiomycosis. Red pigment, Taloromyces. Banana macroconidia points directly to Fusarium. A false positive Crag test is warning you about trichosporon, and relying on the Fontana-Mawson stain to highlight melanin is the absolute key for phaeohyphomycoses. This perfectly distills the diagnostic traps we've talked about.
I'm going to leave you with this final thought. In the arms race of antifungal resistance, the secret to survival lies in uncovering the microscopic clues and lab traps. We just can't rely on broad-spectrum drugs anymore. We have to be true diagnostic detectives. So ask yourself, what other deadly mimics might be hiding in plain sight in your current patient roster? Keep studying, keep hunting for those clues, and thank you so much for joining me on this explainer. See you next time.